اتكلمنا عن gastrointestinal complications. Okay. Before we start, حابة أشكر الناس اللي من ورا الكواليس are helping us وبتساعدنا إن حاجة زي كده تطلع بالمستوى ده. أحب أشكر أستاذ محمود. أستاذ محمود يعني ما ينفعش يبقى فيه أي تجمع حلو كده وفي ناس حلوة كده من غير أستاذ محمود. فشكرا أستاذ محمود. أنت
شرف لينا.
الذكريات بنك الذكريات بتاعنا والذكريات الحلوة بطريقة حلوة وعين حلوة وتواجد جميل وابتسامة حلوة. شكرا أستاذ محمود. تاني حد عايزة أشكره مس إيمان اللي قاعدة دايما ورا، ومس إيمان ومس سماح الحقيقة اشتغلوا معانا في الورك شوب ده بقالنا شهور، وبيشتغلوا بدون كلل وبدون أي صوت ومن غير ما حد يلاحظ وجودهم. لكن بدون اللي هم عملوه ما كانش ينفع أبدا إننا نبقى موجودين النهارده وبنعمل ورك شوب. So I just wanted to give a word of thanks for Mr. Mahmoud, our photographer, and Ms. Iman, our clinic head nurse, and her assistant, Ms. Sameh, because they have given us a lot of help and support without us noticing how much work they were doing. So I will now give the introduction to the
beyond the lungs, other complications in the gastroenterology, Stacey is going to give us a nice talk about that.
Hello, thanks for having me. I'm Stacey. I'm a registered dietitian with our Cystic Fibrosis clinic at the University of Michigan. We know that CF affects the lungs, but it is a whole body disease. And it's very important to understand how it affects the other parts of the body as a clinician, so you can get the overall picture of what's been going on. So we'll go over constipation, DOS, SIBO, acid reflux. We'll touch on CF-related diabetes, and then just a little bit on CF-related liver disease. Constipation in CF. I'm going to start this out by saying it's constipation until it's not. Always remember that. I'm going to finish with that too, and I'll explain why as we're going. So why do we get constipation in CF? So it's that defective CFTR gene. It causes slow motility in both the small and the large bowel. What happens after that? Bloating, gas, bacterial overgrowth, distension, pain. The thick secretions from the mucus also cause poor absorption of nutrients in the small bowel. So you can see that the gut can be highly affected in CF. In the colon, constipation is caused by the thick, sticky mucus and slow motility. Sorry, but this is the Bristol stool chart. It's very, very important a part of the clinical visit so we can assess their stools and assess if our PERT, our pancreatic enzyme replacement therapy, is working appropriately. And we will often show families this because they don't know what this is. And a lot of the times they're very confused at what constipation actually is. So this is not just a tool for a gastroenterologist. This is a tool for the CF care provider so you can understand what's going on. We like to obviously go for the kind of type 3, 4 type. That's what a normal stool should look like. And then with CF, it can vary all the way through, right? Diarrhea, malabsorption, all the way up to very hard, pebbly stools. A very handy tool in your clinic. So how do we treat constipation? Well, we've got several options. First is would be laxatives, and that's usually our first line of therapy. They can be osmotic, stimulating, softening, or bulk forming. In pediatrics, we tend to use the osmotic, which is better known as PEG. We call it Miralax. It's very safe, it's very effective, it's non-habit forming, it's not absorbed. A lot of our parents get very nervous about Miralax or PEG from different things that they've read or heard about. But we've talked with our gastroenterologists. They are perfectly fine with having to use Miralax. If you even need it for the rest of your life, they have no concerns about that. So often as a dietitian, I'm finding I have to convince parents that this is a safe medication. It's been proven and it is effective. But it's not the only one, so that's important to say too. We also have lactulose and milk of magnesium if we need it. Stimulating agents are ones that are going to irritate the bowel wall. So the osmotic ones will draw water in to soften the stool and make it easier to pass. With the stimulating laxative, it's going to irritate that bowel wall, and that's going to be like Senna or Dopalax. Usually, we'll start with osmotic, and if we're not getting good emptying, or our patients are saying, I feel like I still have to go, we will add on something like Senna or Dopalax. I think we usually like Senna the best though. There's also other softening agents. We don't really use Colace too much. I was just talking with our GI fellows. They really don't like Colace at all. They really feel like it doesn't do a whole heck of a lot. So we don't really use that too much. And then bulk forming. So we all know that fiber is good for healthy bowels, but with the CF gut, that can be super tricky because they're constantly constipated. Obviously, we want to help them get more fiber in their diet, but there is something as too much, and we don't want to back them up further. And we really don't have any evidence in the CF community that fiber is going to be that magic bullet to help their constipation. Because we know if you're adding all that fiber, you have to add the fluids too to make it effective. Beyond the medications that we use, we always say, adequate hydration, make sure you're having regular eating patterns for peristalsis, keep that belly moving. It's true, if you don't use it, you lose it. So really try to have normal eating patterns. Try to do a high fiber diet as much as possible. We know with children, that can't always happen. They like their bread, they like their meat, they fight you on the vegetables, we understand that. So we just try to keep practicing it, preaching it, doing it as often as they can, getting in it how you can. We do not expect our kids to get all that dietary fiber, and most Americans don't get the regular amount of dietary fiber, but it's something to consider. For probiotics, we don't have any concrete evidence so far to help with the treatment of constipation in CF. The way that we use probiotics is we do have evidence that if we start it when they're on a really heavy-hitting antibiotic, that it will lessen and reduce the symptoms of antibiotic-associated diarrhea. And there's a couple different strains with that, but that's normally how we use probiotics in our clinic. Now, some of our families will choose to just use over-the-counter probiotics because they think it helps the gut, that's fine, as long as it doesn't cause any harm. But I don't have any evidence that says, yep, this is going to make you a healthy kid with CF. And then movement, like listen, being active, being exercising. When I talk to my kids, I say, what are you doing? What keeps you active? You don't have to be in organized sports. You can just walk every day. We should never discount that walking is good for your health. We're always just trying to dig in and see what each individual kid is interested in. Soccer, football, things like that. Those are great ways to stay active. Keep your heart healthy, your lungs healthy, your muscles, all the good things that we know. A word of caution. You should always assess for constipation before you are adjusting your enzyme replacement therapy, because if you do adjust enzymes and actually they were just constipated, you can make it much worse. So when I see it, or when I have a patient calling me or a mother saying, Stacey, there's grease, you need to increase the enzymes. It's my job to then figure out, do we need to increase in enzymes or what changed? Are they constipated? So we'll go through our questions, any changes in eating patterns, what were their stools like the day before, what has been the pattern, and often a lot of times it is constipation. And we'll say, let's try some Miralax, let's try whatever we can to get it moving again, and then if the grease resolves, you know it was the constipation. More often than not, it was the constipation. They were so full of poop that their enzymes aren't working as effectively, and then you start to see like this overflow of grease. So really, really important to assess for any form of constipation before we adjust enzymes. We do have to educate a lot on that because a lot of parents are like, well, they're stooling several times a day. I don't care. You can stool several times a day and still be very, very constipated. So that's just really working with the parents and helping them understand it. They're never going to 100% understand it, but as long as they kind of get the reasoning. Let's first make sure they're pooping appropriately. Then if we still have grease, then let's consider an enzyme increase. For infants, we'll usually start with prune juice. Takes a very little bit amount of prune juice to help a constipated infant go, like 5 mL or less in small babies. It's got a really great osmotic effect. It's safe. And then we use that under 6 months, and if that's not working, the problem with prune juice is that you keep getting larger volumes, and it doesn't have the same effect over time. And then we always let parents know that. We'll try with the natural things. We'll try with the pea juices, pear, prunes. And if that doesn't work, then we need to move on to Miralax. Constipation in our babies means they're not eating. So when their bellies get backed up very quickly, they might be vomiting as well too. It might exacerbate reflux. There's so many reasons why you want to make sure you are addressing the constipation, the root of the problem. If you are increasing enzymes and not managing the constipation, you're adjusting your enzymes for naught. And then after 6 months, a lot of our kids are chronically constipated. Even on modulators, we haven't seen that the constipation has resolved itself. So Trikafta, while it's wonderful for the gut, we're still working on constipation and enzymes and things like that. So you can also, as they're older, like I said, try lactulose or Miralax. Lactulose is nice. It's an artificial sugar. Our GI fellows like to use that when kids are young, but it can cause a little cramping and bloating sometimes. And we want to avoid suppositories if at all possible. I tell my families for like a rescue medication when the kiddo is distended, isn't going, we need some immediate relief. You don't want to be doing stimulation often and make that anus a little floppy. Probiotics in CF, we kind of already touched on constipation. Yes, they're great for antibiotic-associated diarrhea. So we can start those and maybe get some big hitting antibiotics. Different ways that probiotics work. There's a lot of different research on probiotics. Like I said before, the only thing we know for CF is for the antibiotic-associated diarrhea. Excuse me. These are just some options that we have here. We have so many probiotics in the U.S. I can't say one's better than the other. My thought is it's not hurting anything, and you think that there's a benefit, then that's fine. Unfortunately, a lot of families will have to pay out of pocket for these. Occasionally, we will get probiotics covered for antibiotic-associated diarrhea, but not too often. I'm going to go back to the fiber really quick. So this is a really important part for the dietitian. When the doctor says, okay, we need to modify their diet, we need to help get. So it's very important to teach families about soluble and insoluble fiber, how they both work together to make softer stools. I won't go too much into that, but very, very important part of the overall diet. Yes, we want high calories. Yes, we want variety. And if we can get as much fiber, even better. Okay, so we'll move on from constipation and we'll talk about DIOS. DIOS is known as distal intestinal obstruction syndrome. So it's a complication of CF. It occurs where the bowel becomes partially or completely blocked, usually where the small bowel joins the large bowel. And the reason is that CFTR gene is dysfunctional and it leads to impaired intestinal motility. When you have impaired intestinal motility, then you get a dry, sticky gut. Pair that with malabsorption, and then you've got hard stools that won't move and you can't get them out. These are some images of what DIOS would look like. And the symptoms, abdominal pain, cramping, extreme abdominal pain, distension, can't stool, hasn't stooled in a few days. It's a big swing from their normal pattern. So is it constipation or is it DIOS? They do present differently. Often a hard mass can be felt on the right side where the small bowel meets the large bowel if you have DIOS. So what causes DIOS? Well, it's multifactorial. It happens when the bowel function slows and there's reduced fluid content in the bowel, and then the bowel contents become thicker and stickier. Examples include kiddos born with meconium ileus. They are at risk for that, or had prior bowel surgeries, or even prior episodes of DIOS. Inadequate enzyme administration. So you would think that if we're not dosing enzymes appropriately, we're just malabsorbing. That's true, but if you're not absorbing all of the nutrition, you can actually get forms of stool in there, right? So it's not just absorbing the fat, it's using all of that to make a nice form stool. How else can it happen? Maybe their diet has changed. Maybe they've been ill. Maybe they have an exacerbation. Maybe they have life changes. Maybe they're not getting enough fluids. Usually it's probably a couple of these things paired together. So how do we prevent EOs? So we gotta make sure we take steps for all foods and fluids. We're using our enzymes appropriately and they're dosed appropriately. What we wanna do is avoid excessive doses of enzymes. If you were here for the talk earlier in the week, I had mentioned that that 10,000 units a day really is kind of an old guideline. Most of us understand that as long as we're dosing per meal based on weight, that we're going to be good. If you do overdose on enzymes, you risk causing fibrosing colonopathy. We have not seen it at our center in a long time because we know what we're doing now. That happened when they first got enzymes and they really didn't know what was going on and they gave them far too high doses. So the guidelines are good where you want to have your dose at, but you really should look at each individual patient because some of our patients, especially our short gut patients, will need a much higher dose than standard, and that's absolutely okay. We want to make sure our kids drink a lot of fluids and a lot of salt intake, especially in the hot weather. In sports, I think we all know this. So fluids, fluids, fluids. And one thing that our parents of young kids get worried about when their kids are sick, they're not eating. I don't care, they need to stay hydrated. Let them be sick, get them better, then we'll get back to a normal eating pattern. But it's absolutely okay to just prioritize fluids when we're not feeling so good. Obviously, fiber in the diet. Take your stool softeners as prescribed. This is a constant fight with some of our families. We recommend to take your Miralax daily, use your Senna, and it doesn't always happen. So sometimes it can take months to years to get family and kiddo on board, like, hey, this actually works. Hey, I actually feel better. I'm not having all this pain. So it's just constant education about what CF constipation is and how we manage it. One last point on DOs, if you have diabetes, we want to make sure that the blood sugar is well controlled in the diabetic patients. So when we think about DOs, how does this affect nutrition? Well, it may create a fear of food intake, meaning they eat and it's painful. So we don't want to create that. They may have to go NPO for a few days if they end up needing a surgery or getting a clean out, things like that. DOs is no fun. We can help work on the diet changes to prevent it, increase hydration, and sometimes maybe even changing enzymes. Sometimes you want to look, maybe the enzymes that you're on aren't as effective as another brand, and you don't hear you only have one kind. So you do the best you can with it. So constipation versus DOs. They are similar in symptoms, but they are very different diagnoses. So both can cause bloating, abdominal pain, but constipation is in the colon in both pancreatic sufficient and insufficient patients. Constipation, whether or not you have CF, is a problem for a lot of people. Usually can be managed with medications, laxatives, fluid diet. It's kind of a more gradual. It happens over time. DOs is completely different. It occurs where the small bowel joins the large bowel, and it usually happens in those who are pancreatic insufficient. It can be life-threatening if not treated. And it's a very acute onset of symptoms. And then when they come to our emergency room, they'll get treated with large amounts of laxatives or enemas. I don't even know the last time we've had DOs in our clinic. It's been years. So I think we do a really good job managing that and staying on top of the constipation. Prevention is key. Like I said, it's constipation until it's not. And I learned that at a CF conference. And it really does ring true. A lot of the times it is constipation, and you just have to be a detective. And it's not going to hurt anything just to give some laxatives, just to make sure it's not. Because sometimes you're like, I don't know, it doesn't necessarily seem like you're constipated, but let's just get things moving just to be sure. Now we'll move on to acid reflux. It's caused in CF from the relaxation of the lower esophageal sphincter. Obviously, we have lots of different medications that can be helpful with this. calcium carbonate, H2 receptor agonists, and PPIs. So with the antacids in CF, before my time in CF, I've been here 5-6 years or so, kind of was more use of the antacids, a little bit more, hey, let's just throw an antacid on there. Now we kind of take a step back and say, hey, do we actually need an antacid, or is there other measures we can take? Do we need a different formula for a baby that will be better for reflux? Things like that. Where is it actually indicated? How long should we do acid suppression? Do these kids need to be on acid suppression the rest of their life? We know that there are long-term outcomes, bone health specifically, that come into question on long-term acid suppression. So it's a team effort to say, okay, we've been steady on this, can we maybe try outgrowing our dose? A lot of our physicians will say, let's just outgrow the dose and see how they do. And sometimes it's successful, and other times they become completely symptomatic. So then we'll put the dose back on and try to wean it again at another time. And then there's the idea that H2s versus the PPIs. Which one's better? They both work a little differently. Our clinical pharmacist really likes to use the H2 agonists, like famotidine. It's gentler, less side effects than like omeprazole, which is a PPI. Sometimes we'll use 2 of them with severe reflux. It kind of just depends. One thing to consider with antacids is, do the antacids, can they be used to help the enzyme work most effectively? Technically, there's not research out there that says it does. There's been several papers, but we clinically see that when we have an antacid on board, the stools get better because it makes the bowel more alkaline. So I can give you an example. Like one of our babies, we started an acid reflux medication for vomiting acid reflux, and then, I don't know, maybe not even a year, we're like, okay, let's pull this off, see if we need it anymore. Her poops got terrible blood rash. Now they're helping with the enzymes, so we put it back on board. And I always make note, it's not for reflux, it's for the efficacy of the enzymes. And I don't think that either one is superior to make the enzyme, to help the enzymes, H2 or PPI. We just go with famotidine first for less side effects. I don't know if you've heard this, but SIBO can be a component of cystic fibrosis. It's small intestinal bacterial overgrowth. It can cause excessive gas, bloating, abdominal pain, diarrhea. In very extreme cases, it can cause weight loss, malabsorption, osteoporosis down the road. It's not commonly diagnosed in CF, but my cohort who has been in CF 10 plus years, she thinks it might be underdiagnosed because it can mimic symptoms of malabsorption. You can see some greasy stools. If you're looking at a SIBO picture, and then we don't diagnose SIBO, we would refer to a gastroenterologist, but it's something we think about as a dietitian, nutrition in the back of our heads, and we've done everything we can to make sure that their enzymes are optimized, that they're eating appropriately, and all that. Are we looking at a SIBO picture? SIBO is going to be, you have to rule everything else out first before you then diagnose it. So just different ways you can treat SIBO. We've had a few kids take antibiotics for suspected SIBO. Our gastroenterologists are okay with doing like a trial just to see if it makes a difference or not. It's been a few years since I've had somebody question if it was SIBO or not. Like I said, nothing we see a lot of, but it might be underdiagnosed as well too. Unfortunately, at U.P we don't have a dedicated gastroenterologist with our clinic. So a lot of times as a dietitian and nutrition, we have to kind of play a mini gastroenterologist, try to figure out what's going on, trying to handle the easy things, and then more complicated situations, obviously referring.
So, and actually one of our patients, just to give you a brief.
Yep, go ahead.
One of our patients was having constant abdominal pain, and to treat, we try to start different things. We tried all we can think of. Then we sent him to the GI, and it was SIBO. So, and he got much better on it. So keep that in mind when you're seeing CF patients.
Essentially, we have to play detective, rule all the things we can out, and then say, okay, GI, now you do it. I'm thinking about GI and CF. Obviously, we know appetite greatly affected for several reasons. GI manifestations can impact that. It's not just the kid being picky. It's very multifactorial. And if you do not address the appetite long term, that's going to affect their growth, energy development, all the things. So how do we improve appetite? Well, obviously eating on a schedule every few hours, promoting that gut motility, smaller, more frequent meals if needed. If you have a kiddo who just can't eat a large amount all at once, kind of break it up a little bit more throughout the day. Adequate hydration, adequate exercise and sleep. Don't discount a good night's sleep towards what appetite could be the next day. Prevent chronic constipation. Like I said, little bellies get backed up very quickly, and that will affect their appetite very quickly. That's why we really, really are in the game of preventing constipation versus treating it. Because if you're not treating it, you're getting into this vicious cycle, and they're not eating, and you're just not solving the problem. And then we use medications if we have to. We don't go straight to medications. We try to counsel our patients on these different things that they can do, but we're going to use appetite stimulants because they work really, really well in CF. Dr. Nasser did her own research on that. There are several different options. We stick with cyproheptadine, which is an antihistamine, but it has a nice side effect of appetite stimulation. And in many patients, that we use that in all other clinics as well too. It has very mild side effects. It can be sedative, so we say give it at bedtime. And then we adjust the dose as needed. Usually you'll see a response within a few days. Some kids don't respond well to it, but that's a very few amount. We find it to be very, very effective. And then we can increase the dose. We have certain guidelines on how we increase our dosing. So we're constantly monitoring how's the appetite, are you feeling any different, does it make you sleepy, are you having any side effects? For the most part, it's very safe and well tolerated. There are a few where endoperiatic doesn't work, they don't see that it makes a difference. Or even some that say it makes them hyper. So it's okay, then it's just not something that we use. But it's something that you should use here. If you've got everything else under control and we're still not having a great appetite, can we boost it with some medication instead of asking our children to eat a whole nother meal? Let their body naturally get in those extra calories. And it's not something that needs to be long-term, it can be a short-term, but many of our kids who do need appetite stimulants do need to be on them for a long time. Because what we found is if you pull it off too early, they're growing, they're gaining, great, we don't need this anymore, and then they drop again. So it's a safe and effective medication to use long-term. Now we're going to jump into CF-related diabetes. Do you guys have any, do you have any patients with CF-related diabetes here? Not sure? Okay, we're going to learn about it today. So this is a really big complication in CF. Up to 40 to 50% of adults with CF suffer from CF-related diabetes. So there's two functions of the pancreas, if you didn't know it, the endocrine and the exocrine function. The endocrine is going to be releasing hormones to manage blood sugar. The exocrine is dealing with your enzymes. So a little diabetes overview. Type 1 is an autoimmune disease. There is no cure. They are insulin dependent for life. Type 2, on the other hand, is a little different. The pancreas can make its own insulin, but not enough. And they cannot use it appropriately. So they have also insulin resistance. And they may or may not need insulin. The most type 2 in the United States is the most common form of diabetes, as 1 in 10 Americans has diabetes. And both of these forms can cause high blood sugar. But with CF-related diabetes, it's completely different. It's a mix of the two, so it's not straightforward. There's important differences in the way that it's managed and diagnosed. So like I said, it's a mixture of the two. There is insulin insufficiency. So with CF, not only does it affect the lungs, but the pancreas. So the pancreas gets scarred while baby is in utero, and then it cannot make the enzymes appropriately to help with digestion. So that's one part of it. So insulin insufficiency, same thing. The pancreas also not releasing enough insulin. But there's also insulin resistance in CF, which prevents the body's cells from using that insulin to help lower the blood sugar. CFRD's bigger issue is the insulin insufficiency. Although it is a mix of the two, usually it'll be the lack of insulin being released from the pancreas. So what causes insulin resistance in CF? Chronic infections, inflammation, CF exacerbations, steroids, continual or long-term use of steroids, pregnancy, that can cause, diabetes. So what are the symptoms of CF-related diabetes if you didn't know anything about it? Well, you can see a decrease in their lung function and their FEV1 with no explanation, unintended weight loss, trouble gaining weight even when they're eating all the calories, very fatigued. Those are just a few of the symptoms. I will tell you, when we diagnose diabetes, sometimes it's just the tests that tell us that they have it. The kids will be asymptomatic, they don't feel anything, like, I don't have diabetes, but then when we do their oral glucose tolerance test, well, you're positive, we need to send you to endocrinology. So when we're thinking about what are the symptoms of diabetes, in general, increased thirst, polydipsia, polyuria, they may have increased hunger, blurry vision, slow wound healing, numbness, tingling in the hands and feet, the darkening of the skin. We don't see DKA in CF, that's more of a type 1 diabetes issue. So how do we diagnose it in CF? So currently, per CFF Foundation, we start screening our patients when they're 10 years old, and we start doing the oral glucose tolerance test. This is the same test that a pregnant woman would use to check for gestational diabetes. So we do 2 blood draws. It's going to be a fasting 8-hour blood draw, and then they take the glucola drink, and then they'll get another blood draw 2 hours later. So we want to see how their body is handling their sugars while they're fasting, and then after they have a very high sugar load. And a word of note is we don't use hemoglobin A1C to diagnose CF-related diabetes because it's not a good tool. Persons with CF, their blood cells turn over differently, so their A1C is not a good reflection of what their 3 months of blood sugars have been. Sometimes we'll see an A1C of 6.1 or 6.2 when they're sick. So that's a default, it's high, but it's high because they're sick, and when we check again, it goes back down into the 5s. So unless it's like 6.4 and above, you're really seeing a diabetes picture. It can kind of be like, what is going on here? Usually it's because they're sick and they have an exacerbation. So families get very worried, but there's really nothing we can do about that. This is what their bodies do when they're not feeling well. But it's also reassuring to them that no, at this point you don't have diabetes, but it's something we're going to keep an eye on. So the labs that we're looking for.
I just have a couple of questions about it. So it's the A1C. It's just because it gives us a raw picture of the past 3 months, so it's not that accurate, or
so their red blood cells turn over quicker than ours do. So it's really not like a 3-month average. It's more like 2, 2.5. Basically, if you're looking at a hemoglobin A1C in a patient ranging from mid-5s just to low 6s, that's not necessarily a diagnosis because being sick will raise it. The OGTT is the confirmation. It's not the confirmation. That's when we send them to endocrinology and they'll start monitoring their blood sugars a little bit closer.
Okay, and also like the age that we start screening is 10. We never saw cases before that.
So that's
like the incidence is way less.
Yes, exactly.
Okay. So I guess that's why we don't see them here.
We do check A1C in our younger kids. My cohort who's been in CF longer, she just implemented that. She just wants to see like what their A1C would be, and I do see some higher A1Cs in our kiddos when they get their blood checked, but it's not related to anything.
And also, like you said, it's a combination of type 1 and type 2. Is it like more of the early onset diabetes, like the maturity onset diabetes of youth, and we go to this pathway, or is it different entity that we have to deal like with diabetes of CF, not like any other?
It's not like any other. I wish Dr. Nelly would be here with us to explain more.
Right, so we have kids younger than 10 that we diagnosed, and these are the kids that come in with frequent exacerbations, and we treat them and they're still not doing as well. And when they come, we usually do random glucose level, and you find it as high. The hemoglobin A1C, we use it because the CF Foundation ask us to, even though it's not diagnostic, but it could help. But generally, it's not. It helps in the follow-up rather than on diagnosis. So we do the OGTT if there is indication before like family-free, like patient getting sick. We have a 5-year-old that ended up diagnosed. We have an 8-year-old that was diagnosed, and he was actually type 1. Even though CF, but he was like they did the testing and they said it's type 1. So yes, the OGTT generally you do it at 10, but definitely you have high index of transmission, do it earlier, and then also have your endocrine group with you because they can help type 1 or 2. Most CF diabetes is insulin sensitive, so they do need insulin. Very rarely, right now, our endocrine group are testing with the, can we use the oral medication for diabetes? I haven't seen that anywhere, and they are, they're working with it. So I'm really interested to see what the results is. But the general thing is CF diabetes, insulin, period.
Correct. And they may not always need insulin. Some of them will get a positive diagnosis. We'll send them to, to endocrine. They start monitoring, and everything is normal. And so then we decide, okay, do we just go back to regular OGTTs the following year? So it's a collaboration. It's not a straight answer. We really let endocrinology help guide us. This is what you're looking for. So a fasting result over 126 could be indicative of CFRD. We generally don't see that. What we see is the 2-hour result is over 200. But we have also referred when it's close to 200. So like I have a girl she's like 9 or 10. She has a history of short gut, and she was like 198, and she's not growing. I'm like, endocrine, please. Like, is there anything we're missing here? No, she didn't go above 200, but could there be a problem here that we don't really know? So like I said, if it's in the mid-6s, over 6.5, that's going to be your diagnosis, right? That's what you're going to see with a true diagnosis of CF-related diabetes. Anything lower than that, it's not indicative of it. It's not the identifier.
So the endocrine group would say, even if your OGTT normal, but you have hemoglobin A1C over 6.5, send them to us anyway.
Yeah.
And they start the monitoring.
Yeah. So, we have different tools to help treat CF-related diabetes. So the endocrine clinic, it used to fall on home clinic, but now our endocrine cohorts are helping us with this. Getting the glucometer, having them check their blood sugars, keeping some logs for them so they can kind of see some data, right? Get some numbers and see if we actually need insulin or if we just need to monitor a little bit more closely. It's important to remember as a clinician with CF that very few people with CF have normal glucose levels. One study found that up to 75% of adults with CF have some form of glucose intolerance. Well, that would make sense if there's 40 or 50% of adults with CF who end up with CF-related diabetes. So we're hoping in the future we will get more glucometers or continuous glucose monitors so we can see those highs, see when they're spiking up. Obviously, we treat with insulin if needed, and like Dr. Nasser said, sometimes we will get a type 1, and they run extra labs, and there are certain antibodies they're looking for. So I can think of a couple that have been labeled type 1 for us, and they're on insulin pumps usually. And then, as we talked about, metformin. There historically have not been a place in that in CF-related diabetes because it's not just an insulin resistance problem, it's an insulin secretion problem. I do have one kiddo that endocrinology is trying metformin on right now. I don't know if it's doing anything or not, but she did several tests and she thinks that his CFRD is more insulin resistance. So it's not hurting anything to try the metformin, but we don't know actually if it's doing anything just now. But we do have someone on it, but it's not the standard of care. Insulin is the standard of care if needed. And then continuous glucose monitors, I'm sure they're expensive here, they're expensive at home too, and we have to fight with insurance all the time to get these because they don't recognize CF-related diabetes. So we're still struggling with that in the US. Insurance companies want a type 1 or a type 2. They don't understand that there's this third type here and that they need this. So sometimes families will pay out of pocket just for ease of mind, but hopefully in the future, all the dietitians would love to see our kiddos with continuous glucose monitors if we're suspicious that they might have CF-related diabetes. So when you have CF-related diabetes, just something from a nutrition component, carbohydrates raise the blood sugar really, really quickly. Proteins and fats minimally affect it. And then there's just different types of sugar, how it affects your blood sugars. This will be more for endocrine, but just know, carbohydrates, lots of carbohydrates, high blood sugar. Easy enough. So then how do we counsel them? We always try to promote balance as much as possible. Pair carbohydrates with a protein and a fat to slow down the digestion so the blood sugar does not spike up. Eat in normal intervals. Continue to eat your high-calorie diet, but try to make it as balanced as you can. So that is tricky for our patients. Wait a minute, you want me to eat high-calorie, but now I gotta be low-carb. So we try to balance that out as best we can and really educate the families on what they can do dietary-wise. Because yes, dietary-wise, you can help control your diabetes by changes in your diet. But in CF, that's really hard, right? So how can we work together? If you have insulin or you need insulin, take your insulin. And we can keep working. I'll give you an example. We had a teenager, he was in the emergency department for several days waiting for bed, and he had diabetes, and the pharmacist called me up, oh my gosh, he's eating all the time. What do you want him to do? He's in the ED sitting there. We're not going to solve this acute problem right now. Make sure you give him the appropriate amount of pancreatic enzyme replacement therapy. Make sure, he's getting the right amount of insulin. That's all you can do. That was not his acute problem. What are you going to do if you're sitting in the ED for a couple days straight?
So it's a constant conversation with the endocrine group is that if the patient is diagnosed with diabetes, we should restrict the diet, we should do this. We have an agreement with them that the CF cannot do that because they need a lot of calories. A lot of them some of them have G-tube, like gastrostomy tube feeding, and that's really through the endocrine group, off, because it's hard for them to control the blood sugar. But it's a constant collaboration with us and the endocrine. That's why you really need a good endocrinologist here that can work with you on that.
Absolutely. And we can educate, very simple, liquid sugar, right? So we can tell our families, try to limit the juice, the soda, things that we know will spike blood sugars, right? We can't completely cut out carbohydrates, but can we cut out the ones that we don't really need as best we can? And then, artificial sugars, there's plenty of hot debate about whether or not artificial sugar is good, bad, whatnot. Yes, they're synthetic chemicals. They're often called low-calorie or non-nutrient sweeteners, but they can be a useful tool if you're struggling with your blood sugar or reducing the amount of sugar in your diet. It could be an option. If it's not hurting anything at the moment and we need to get better blood sugar control, will a diet soda be better than a regular soda? Absolutely. Now, then we get into the other debate, is soda in general healthy? We'll do one thing at a time. And then other ways, not just insulin, right, and diet modification influence. How do we, keep CFRD in check? Obviously, we want them to exercise. That helps control blood sugars, keep them hydrated, and good adherence to their CF treatments. Keep your lungs healthy. Keep everything as healthy as you can so that we're staying out of the hospital. There are many complications with diabetes. These are obviously going to be more long-term for people who are not taking care of their diabetes. It can cause slow gut motility, vision issues, diabetic neuropathy, so many reasons. We know why we want to make sure we're managing our blood sugars. And then the last thing I'll touch on today is CF-related liver disease. We do not see much of this in the United States, and we have hepatologists that help manage any of our kiddos that do have CF-related liver disease. But really the pathogenesis of it is poorly understood. But what they think is there's that buildup of that thick, sticky mucus, the bile ducts get blocked, and then there's inflammation and scarring. The symptoms of CF-related liver disease: blocked bile ducts, cirrhosis, fluid, jaundice, high blood pressure, malnutrition. 5 to 10% of CF patients develop major liver complications. And we really don't, like I said, we don't see it much. We did just have a kiddo that was transplanted, though. He came to us very sick. And so we do have a current transplant patient. He's still admitted. Several ways, obviously, to treat it. Liver transplant being the end-stage option. What different types of things you can do. You can try with dietary changes as well. But again, like CF-related diabetes, we still need a high-calorie diet. So that one can be a bit tricky. But we definitely look towards our hepatology doctors to help guide us on this. And that's all I have. Any questions? Yep, go ahead.
If CF children recommended for resection, the main reason will be failure to thrive, or they may have some oriented dysfunction. What is it?
About the G2.
Yeah, so a G-tube is a tool. It's not something everybody needs, and it's a family, a team discussion. And we really try to do it sooner versus later, but a lot of parents are very hesitant. There's a stigma around having a G-tube, putting something in your belly, it's another surgery. But we really, as a team, do a good job of saying this is needed. It doesn't need to be for a long time, for the rest of your life, but you just can't keep up, and it's nothing that you've done. We just have to get supplemental calories in, and we try to do it sooner versus later. In our kiddos with CF, we skip the NG tube if we can. Just go right to the G-tube. They're going to need it for more than 3 months. I've worked across multiple clinics, and this is the clinic that I absolutely agree with, that you should be putting a G-tube in when it's indicated, because you just don't need to mess with an NG tube. It's messy, it goes in their nose, they don't like it. Just put the G-tube in.
So we have an algorithm, actually. We have an algorithm when to start talking about the G-tube. So we first start with high-calorie diet. We start with, and then we add supplements. Then if that doesn't work, then we treat if there's infection, if there's anything like that. Then we do appetite stimulants, so tireoxetine or supretilene would be the one to do. And then if everything fails, then, and we know it's a matter of needing more calories, we talk about the G-tube. So in my clinic, how many do we have in the G-tube? Maybe 5 or 6?
Oh, maybe 20.
20, in mine, but we have, my colleagues see patients as well. So about 20, but our total number is 275.
Right.
So it's not that huge number because we do, and through that process, we talk to the family. So we can get them to agree with us or tell them what we're doing. So we're gonna do this and then we're gonna do this. One family, I told them, okay, if everything fails, we're gonna do a G-tube. The kids do marvelous. The family's been doing everything in their power to get the kid to gain the weight. And that's important, to work with your family, but it's a process, it's an algorithm. If you wanted the algorithm, I'll share it here. But we start high calories, supplements, appetite stimulant, then we go to the G-tube as a last resort.
I would say the only reason we would jump to a G-tube with feeding difficulties with infants, they're unable to tolerate, or they get orally averted in the NICU because they had to be NPO for their major gut surgery. So I have 2 orally averted kids right now, 100% had to go right for the G-tube until we can get them eating again and adding to that. So that would be the one point where we would say, nope, okay, we gotta go right for that so they can get their nutrition.
But yeah, not very common.
Yeah. Any other questions?
Other questions? So I have a question. PPIs, or proton pump inhibitors. When do you consider adding them, and when do you consider removing?
Right. I think it's very doctor dependent. Some are more apt to start it sooner. Some are more apt to maybe wait a little bit and see if we can improve it in other ways. Our pharmacist, Hannah, she always likes the famotidine. I'm not as well versed in antacids, but from my understanding, the H2 agonists just seem to be better tolerated in the pediatric population. And then if you increase it, you start at once a day, increase it to twice a day, you're at max dose and you're still having reflux symptoms, then add on that second agent. I think generally is how it goes. I know there's not necessarily a time to do it except for when they're symptomatic. Yeah. It's not something we just start on automatically.
Yeah. I think here it seems like a lot of people started automatically with the enzyme, thinking that it will help with the enzyme effectiveness, but in the yes, we use it only in our symptoms of reflux. As she said, we start, I like PPI more than famotidine and all of these, so I usually start with it if the pharmacist doesn't stop me.
Everyone has a different opinion, I feel like.
Yeah, but so yes, but we don't use it unless there are symptoms, so we don't use it all the time. Yeah.
Yeah.
you do macro distribution, like what I said, 40 parts, 40 fats, and 20 protein?
So like when you're calculating needs or something like that?
Yeah.
No, it's just not necessary. We take what they're doing right now and then we add to it. You learn that clinically, but practically on the outpatient side, it doesn't matter. We need to get more calories in. So usually it's fat, we'll get more fat in because that's the easiest for kids. If you look at the distribution, if we're doing enteral nutrition, then it would probably be more a little bit like that. We'll start them on a standard formula, see if they can grow on that, and then if not, we can switch to hydrolyzed. We do not start just with hydrolyzed though, because insurance don't let us. But it's not always indicated. Some of our kids do tolerate a standard intact formula, so there really is no reason you shouldn't try that first and see if they can tolerate it. And then enteral formulas are, manufactured to be complete enteral nutrition if they need to be. So we don't, just practically, we don't worry about it. Oh, from their diet? No. It's just, it's too time consuming. What we'll do is just look at what are you eating throughout the day and how often, so where can we maximize where you're eating. So like, for example, the mother was here last week, she said her son only ate like lunch and dinner, so he's having a big part of the day that's missing calories. So the calorie distribution doesn't matter to me when he's just overall lacking in calories. So how can we add to that? So clinically, outpatient-wise, you don't need to, you can, but there's just so many things we're trying to manage that looking at that macro and micronutrient distribution, it's just not necessary. Plus, we already have vitamins on board, and we're treating the deficiencies if there are some. I will tell you, they're going to be 40 or 50% worth of fat, I'm sure, if you were to analyze it straight down.
Because we are very much focused on this distribution to increase the fat content of their meals.
Yeah.
Then I came across the trikafta.
Mm-hmm.
Okay. Does the additional trikafta affect how we will adjust the macronutrients?
That's a very good question. So that's kind of to be determined. We know when it started in our teenagers, they gained a lot of weight, but it did plateau. They didn't consistently gain, right? We don't know why. Same thing with like the liver enzymes. We know trikafta affects liver enzymes. They do go up, but at some point they do okay. Now, obviously that's not true for every single individual, but that's just kind of the overall. So starting it in these younger patients, we don't have data yet on whether or not it fixes or improves weight gain. I'm actually going to be writing up something for our 2 to 5 year olds. We're looking at that right now, and then vitamins too, how trikafta affects the vitamins. When our kiddos usually start trikafta, they have what's called the purge, and they have mucus coming out. Their stools are very, very gross, and it's that, getting all that thick, sticky mucus out of there. There are questions about pancreatic sufficiency, if the patient will convert back to being pancreatic sufficient. It's not something that's widespread, and it's just very individual cases where we've seen it, so it's not something that we say, don't expect to turn pancreatic sufficient. A lot of that damage was done in utero, and so we don't know. There's a lot we don't know about trikafta, but I will tell you, yes, it's great. Yes, it helps with weight gain. In the younger kids, we don't know. We just don't have the data yet. But seeing it in clinic, I'll tell you, the 2 to 5 year olds, not a whole lot of weight gain. But my thought is we have all these treatments, all these antibiotics, all these enzymes. We would have ways to keep them healthier younger than we did 20, 30 years ago. So trikafta is great, but there's a lot of unknowns still. I've only had one, and he was, I want to say 10 or 11. He converted from insufficiency to sufficiency, but he was more of a milder. So the trikafta seemed to help him. But I haven't had.
We're not seeing.
It's just not something. But all the parents, they keep talking. Oh, check. We have to let's focus on what it's here for. We can always check if they want to, but a couple that we've checked, no, they're still pancreatic insufficient.
We might be able to reduce the enzyme dosing, but no, nobody's converted except very, very rare cases.
Yes, and when our teenagers got on trikafta, they're like, yay, great! Stop taking their enzymes. The weird or odd thing is they don't present with malabsorption without taking their enzymes. So we have a real hard time as a team convincing them they need enzymes when they're not having steatorrhea. They're not having loose, greasy stools. We don't understand the mechanism of it, but we test and they are still severely insufficient. So just because you can't see the effect of the enzyme doesn't mean you don't need them. We don't know long term what it looks like to not take enzymes, you know, over 20 or 30 years when you need them. And they grow and they gain too. It's the oddest thing. We don't understand it, but we just try to educate. Can we have you at least take a small dose? Can I convince you to just take a little bit and go from there? So Trikafta is great, but it's very a lot of unknowns still.
Any other questions? Okay, before we conclude the session, I would like to invite all the pulmonology team to take a group photo.